Welcome back, everyone, to another edition of Dermatology Grand Rounds, Atopic Dermatitis Edition. I'm so fortunate to be joined by Melodie Young, and we're going to get into some really fun cases. And of course, there'll be a lively discussion. Welcome, Melodie.
Thank you. Glad to be here.
So let's just dive right in. And we're going to go back and forth. You got a case, I got a case. Let's have some fun. So we're going to start with one of my cases. This is a 44-year-old male, long-standing history of eczema, aka atopic dermatitis. As you can see, has some familial comorbidities like asthma. This has been going on for a long time, but over the last 4 weeks, has noted that it's gotten a lot worse, especially as you can see here on the photo inserts on the face. Claims there are no new exposures, though I would say looking at where there's some prominence of these very geometric, well-defined plaques on the beer line, you might wonder about maybe some outside job here in addition to his atopic dermatitis, but he's pretty unhappy with the way things are going. I did throw in some of the more like researchy oriented tools like IGA, which goes on a scale from 0 to 4. I say 0 is none, 4 is train wreck. And this guy was miserable. While we're only seeing his face, he was covered, BSA of over 45%, itching like no other, was not sleeping. And just to throw out there, he also said, I'm very much in the public eye. I need this to be gone yesterday. So with all of that, what would you do here?
So one of the first things I noticed exactly what you're talking about. I in the NBA player James Harden, sort of got the big black beard thing going. I had several cases of people who had a even milder atopic dermatitis have significant reactions. So it almost is, in the psoriasis world, we would call it a Kebner effect. And of course, atopics can do the same thing in areas of irritation. Would be thinking about that. I would throw the book at him. I would definitely put him on a biologic, IL-13 inhibitor, most likely, possibly a JAK if all circumstances were right, just to get the itch relief, and then topical medicines. It'd be very tempting to give him IM Kinlog while
I love that you said that.
Now, while I start the other thing, because I always say an IM Kinlog is like Cinderella's slipper. Right? It's good for a moment, but the clock will strike 12 and that benefit is going to go away. And so you're going to have a foundational biologic, because this is not just a one-off thing.
Honestly, I knew the moment this recording started that you and I were going to be good friends, because I think we're unicorns. Like the utilization of intramuscular Kenalog has kind of like disappeared into the ether. And it is such a wonderful way to capitalize on systemic steroids without the baggage of oral steroids. And yes, you're putting it in there, it stays in there, and it comes out very slowly like a depot in the fat of the buttock. But it is a way to administer steroids without some of the more concerning features of whether it be high-dose oral steroids and beyond. And I agree, I actually employ that a lot in my practice. I only do in the buttocks. I know some folks like to go for the deltoid. I'm very against that. I think there's more risk for atrophy and notable atrophy.
I can show you the dimple myself, and I work with Jennifer Cather. We have an opposite butt cheeks. Both of us have got a bit of a dimple.
You can still get those dimples for sure.
Kim Kardashian had one, made it famous. So IM Kinlog, it's a reasonable thing, but it's not. I won't do it except for that would not be this man's new care. It'd only be an adjunctive therapy, or just like
I agree. It buys you time. Because it kicks in within a couple of days. It buys time for the right setting. And I think you brought up such an important point when you mentioned biologics, JAK inhibitors, even intramuscular Kenalog. We have a smorgasbord of options, so we can actually tailor our approach to the patient, not say, we got this, and regardless of what's going on with you, this is what we're going to do. And it's such a fun time to manage atopic dermatitis. So very much on board with what you were saying. Right out of the gate, we're starting him on a biologic, which to your point will take some time. And along those lines, I'm also not shy even using a class 1 steroid for a short amount of time, even on the face. When I was trained, oh, you never use class 1 on the face, on the genitals. Why? It's all about meaningful and purposeful use. For a couple days, you're not going to cause harm. The things we're worried about, like hypopigmentation and skin atrophy, that comes with prolonged use. So I started talking about topical steroids, and I got this patient, kind of morphed into this hysteric individual. Steroids are the devil, and they're not. But we have to appreciate that steroid phobia is a very real entity. Plenty of publications speaking. This is from 2011. So this is something that's been in the ether, in the literature for some time. And so I think we have to be prepared to talk about patients. That said, we live in a world where there are other options. But the fortunate thing about this being out there for so long is that we have great colleagues who have done the work to show that even super potent topical steroids, when used purposefully and following the indication, you don't run into issues. This was a paper, again, relatively older paper at this point by Tina Butani's group out in California, where they showed that you really would have to push the total amount per week to really impact the kind of more concerning side effects, especially when you think about adrenal insufficiency, HPA axis suppression, let alone the cutaneous adverse events. But sometimes the path of least resistance is the easier one. And so we live in a world where if a patient pushes back, we've got options. And I highlight this podcast I did with the great Raj Chovatia, kind of talking about that paradigm shift in that our non-steroidal armamentarium has grown tremendously. And I think that we are creatures of habit, and that, we are so used to topical steroids, but we are growing that other bucket with things that have unique MOAs, unique targets that don't come with some of the baggage of topical steroids, especially that phobia. So Melodie, do you get pushback when you're giving someone a topical steroid? They're like, oh no, that's not for me.
Yeah, I do. And I have seen complications. I've had patients, referred in who had been in ICU for adrenal suppression from overuse of topicals, lots of striae. And I have had people develop it, grab the wrong steroid, because what we know and what we're comfortable with, we understand the class 1, class 5, what you put where. But it always says don't use on the face or genitalia on the box, that they throw the box away. So there's a lot of opportunity for error. And they've all heard a story. It's very big on social media right now. And I mean, I have seen even wasn't it the New York Post a couple of weeks ago, a big article about a person who had overuse of steroids or topical steroids. It is absolutely possible. So I think it just allows the opportunities. And the way I look at it is this is a short-term situation. I'm full of little colloquialisms that always say steroids are like the Marines. Their job is to get in there and then get out, and somebody else has to come in and take over and manage everything. So we can do that. Steroid shot in the booty, steroids on the face. Look, in the OB-GYN world, they use class 1 steroids on the vulva all the time for LSNA and other sorts of things. So I'm not afraid of it, but I just kind of give them, here's the parameters. It is short term only. Chronic disease, we're going to keep going. I mean, if it's, chickenpox or poison ivy, I don't have a thought about it because it's an acute situation.
Right.
But in this guy, you said he's had this long standing, and he's probably had a lot of steroid from asthma. And that's another conversation. Why is he afraid of it? And a lot of times it will be because they've used it for another condition, Crohn's, ulcerative colitis, and they've had, overuse. And I think it's very judicious on their, within their thought process to say, now, let's explain to me, Ricky, what's going on here? Like, what are my other options?
Yeah, and you bring up a good point, acute versus chronic. We're dealing with a chronic disease. We're not going to cure it. In the acute setting, I love that, send in the Marines. I say, you want a hose to put out the fire, but then you're going to have a more kind of modified, complex, and thoughtful approach to like maintaining and repairing. So you want to knock that fire out. And in the acute setting with toxodendron dermatitis, certainly steroid, knock it out, it's gone. But for chronic disease, one of the issues, and I think one of the frustrations of patients, is they use a medication, they stop, and it comes back. And no one even told them, oh yeah, by the way, when you stop, this is going to come back. So a long-term strategy is going to be very important. So, all right, no steroids for this guy. All right, let's do roflumilast, 0.15% cream, which is approved for atopic dermatitis, and it's once a day. So we think about also when we have to consider adherence, there is a big difference between having someone put something on once a day versus twice a day. Both are easy to say. It's different to actually have to execute. However, we also live in a world of access issues. And, of course, we have to be very thoughtful, not just in terms of what medication can we give a patient based on the payer who supports them, but also where do we send it? How do we document? How do we set them up for success? And we do that on our end, in addition to having hopefully a prior auth coordinator, a biologic coordinator. It starts with what we document. Pick the right ICD-10 code, document failures, document the disease state. You will save yourself time and possibly a negative Yelp review if you get that stuff in there to avoid the kickback from payers. So we have to absolutely consider not just what drug for the patient based on their preferences, based on the disease, but what can we actually get for the patient and what can we do to really contribute to making sure it is as smooth a process as possible. And so this is this patient 4 weeks later after starting lebrikizumab, getting the patient on roflumilast. Now, at GW, I'm very fortunate we are able to give samples. We're talking about unicorns. We're probably unicorns in the academic world. So I was able to give this patient samples to start. And right off the bat, you're seeing substantial improvement. I'm not going to say it's from the roflumilast. It's probably a mix of the two, but we know biologics do take some time to work. But already out of the gate, we're seeing improvement, which then will only further that adherence down the road. Melodie, some final thoughts on this case before I toss it over to you for yours.
Combination therapy. So in the clinical trials, almost always monotherapy. And I think the key is when you have a bad case, you're just going to do it all. Short term, long term, just do it all. Everything within your power, you got to do that.
Dump it out on that.
Yeah.
The kitchen sink and everything else.
All the sauce.
All the well, you're in Texas. It's all about the hot sauce. I totally get that. So, all right, let's move on to your case.
Okay. So yes, I'm going to tell you about a kid that sort of grew up in our practice. So he had been coming for more than 10 years since he was in junior high and had always had his biggest area of concern, neck, upper chest, which is not uncommon. We see that a lot face. You'll see in the pictures. He, of course, had it other body parts, just all those sort of hot spots. When a person comes in to see you and they say, hey, I have eczema, and you look, yes, you do, on your arms, and you might look around the face. And even if they're dressed, you know where to look to confirm the diagnosis, where I'm going to see it. And this kid had it exactly in those areas. It had impeded some of his life skill options because of his hands and feet, trying to figure out, he wanted to be a mechanic. That was problematic. And it had the triad as well, seasonal allergies, asthma. So because it was very focused on hands and on face, we did the contact dermatitis look as well. And, then I'll show you what kind of happened. So we'd managed him for a while. We'd had him in a trial or two. So you can see what he looked like. You can see that underlying erythema. And then when he was having his flares, which he would have several times a year on the right-hand side. It was his eyelids, his whole face, just that redness that he would have. So we had put him on, finally tried a couple of different therapies. So I tried an IL-4, IL-13 inhibitor, and he did not do well. He did okay, maybe 50%. And of course, what you do if they're not as good as they need to be, they're still having flares. You're like, well, let's try a different biologic. And then, of course, then we had some new topicals that came in the market to look to see if he had plenty of steroids. So we kind of got him better. And I just so happened to say, hey, let me see, because his face was better. I want to see everything else. Pull your shirt up and see this spot in literally 24 years old. With this significantly concerning lesion, Clark's level 3 malignant melanoma. Do I believe it was related to any of the because these biologics are not immunosuppressive. He had plenty of steroids in his lifetime, which are, I think it was just bad luck. But the moral of the story here is when a lot of those pink scaly patches go away, when you're treating psoriasis or AD or whatever, make sure you still are doing your skin checks to see what else is happening. Because a lot of times they don't want to take off their clothes when they have such bad skin disease. So keep that in mind. So I saw him recently. He's done great on, we finally found the biologic for him that's the most effective. And I added roflumilast again to, just sort of gave him some samples initially to see if he could tolerate it because so many other things had burned. And he is, for the first time I have known him in over a decade, completely has normalized looking skin on his face and eyelids. And then I did, of course, do the melanoma checks on him now. You can see a little bit of underlying disease on the back of his knees, but he's not using topicals there because it doesn't bother him. He doesn't really care, which is fine with me. So treated him to his target. And then also, do just the good, that relationship care. I don't want him to doctor hop. I want him to stay with us. And I think that should be one of our goals. Like being there with him to say, we're going to solve this problem so you have the chance to manage the other things, including melanoma in a young man.
Yeah, that surprise melanoma, I think you bring up such important points. And sometimes, so I've seen cases where, for example, someone with psoriasis, they clear and like, I have one more spot of psoriasis left, one spot and it won't go away. And, when it comes to, for example, squamous cell carcinoma in situ, Bowen's disease, it can look inflammatory. And often there are cases throughout time where it's called eczema or psoriasis because it looks inflammatory, it's scaly. But I think the point you bring up is one, please look, but two, if you have something that's not responding the way it should, given this patient was doing really well on everything else and cleared, and they have this one area, go back to the drawing board, do a biopsy because it may be something else. So that's really important to always look, make sure you're checking, don't just take the patient's word for it. And they may also not want to show you, they may be embarrassed if it's an area like the genitals. And then always consider, that's weird. Why is that one spot not going away when everything else is doing well? Well, it may not be what you're actually treating.
Yeah, I have a lot of photos of superficial basal cells, especially in people, having done this job for more than 30 years, you know people for decades. And when somebody that I used to treat comes back and I go, are you completely clear? Well, all but a few spots. And you look and I go, those aren't psoriasis, superficial basal cells. And they've been putting steroid on it consistently for off and on for a long time and they just wouldn't go away. So yeah, if something doesn't clear, rethink your diagnosis for sure.
So the message is always look and trust your gut. If it doesn't make sense, it's always okay to take a step back and reconsider what you're looking at. Well, Melodie, this has been so much fun. No surprise. It was great chatting about these cases with you, kind of pulling and plucking out those practical pearls. And I hope everyone who joined us learned a couple things or two to add to their clinic tomorrow.
It was fun. It was really fun.